Today on the Beauty Doc podcast, I have our subject today is male facelifts and how the analysis, planning, and execution of facelifts for men differ greatly compared to women. And I have as my guest Dino Elyassnia, who is a distinguished plastic surgeon in San Francisco, who has written extensively about facelifting and in particular has written a manuscript co-authored with Dr. Tim Martin on facelifting. And I am very pleased to have him as a guest because I feel he's an expert in not only facelifting in general, but in this subject of male facelifting. And I look forward to his insights into the differentiation of male facelifting compared to female facelifting techniques and what things they have to consider when they do male facelifts compared to female facelifts. So to begin with, Dino, could you please, I'm going to call him by his first name, and I would like to ask him, how do you distinguish and differentiate between men and women in terms of their overall facial anatomy, in terms of how you approach men?
Yeah, thank you. For me, the biggest, so first just starting artistically, because that's really the biggest difference. Obviously, men and women age very differently in a sense. Now, we're all generally getting laxity and the quality of our skin degrades and we have volume loss. But the way that a male face changes is different, and there's some advantages actually. So the common reason for a facelift is people get jowling hair. Now, for men, a more square jawline looks okay. So a little bit of jowling doesn't really degrade the shape of the jawline. But for women who want that really, tapered look to the jawline, especially now with these, Instagram filters making everything look even more sort of, princess-like,
Mm-hmm.
that any bit of jowling really starts to masculinize their face. So women need a little bit more comprehensive treatment, whereas for men, we can do some more spot treatment. Now, the key area, I think, for men is the neck. And part of the reason is what I just described for the jawline. If the jawline's not such a big deal, we can really focus on the neck. Now, it doesn't mean we never treat the jawline in men, but our the age can be greater, or you can do just more isolated treatments like just the neck, because it's they tend to be more conservative and that's their focus. And if you look at a really beautiful male and female jawline, they're identical. So it's the one area that we can be very, very aggressive to create a very sharp transition from jawline to neck. That
Okay.
transition, making that sharp, in the prettiest young men and women, it looks very, very similar. So ultimately, the most common thing that I do differently in men is I do more isolated neck lifts, and we're more sort of conservative on the rest of the face, especially the eyes. Whereas for women, we're a little bit more comprehensive.
Okay.
Um, yeah,
I'm gonna step you back a little bit because I think of when I think about facelifting, I think about the three components: skin, the skin quality, the sagging, which changes the contour, and the volume loss.
yeah,
Can you
same.
address can you address each one of those components in regard to men versus women?
Sure, yeah. So for men, let's start with the skin.
Yeah.
Again, less of an issue because lines kind of keep a man looking a little bit more rugged. It's a little bit more, let's just call it socially acceptable. You see often the romanticized male figure often will look, rugged and have a lot of lines. Women have less tolerance for it. They want smoother appearing skin. So basically that means we're just going to do less on the skin for men. Plus, men
So,
are less likely to want to have resurfacing and the downtime of resurfacing, that kind of thing.
okay.
Volume loss,
Would
I
you,
would
by the
say,
way, can I back you up for one
yeah, sure.
second? So how would you approach the skin resurfacing on a man? Would you use a laser? Or would you use a chemical peel? Would
I, um,
you?
I mean, I use a laser in the office, so it's the same I would use for men and women. I wouldn't vary it.
Okay, okay,
Yeah, just because that's the technique. I don't think it matters if you're proficient with any of the types of resurfacing. I think you can do whatever you're good at, kind of thing.
okay.
Um, uh, Volume loss, so the second component, I think is pretty similar. Um, Same kind of areas of volume loss. It's really not that different. The only difference is, again, for women, we want to create a more kind of defined cheekbone. It's just the artistic shape that we're going for. So for men, this distance between jawline and cheekbone, it's going to be closer to being similar, basically. Maybe the jaw comes in slightly. If the jaw goes in really, if the jaw is really wide, then people look, it makes men look a little bit sort of caveman-y, a little. And whereas for women, we want that the opposite, a little bit more cheek width versus jawline. So those kind of artistic differences just affect where, because I do a lot of fat grafting with my facelift, it affects where we put the fat and how much and the distribution. But ultimately, I think the aging process is similar in terms of volume loss.
But now, in my experience with, for instance, with laser resurfacing, I'm going to back you up for one second because
Sure.
when I laser resurface, I know you said there's you do similar techniques, but I find that men heal much quicker after laser resurfacing because the number of hair follicles they have on their face. I think it helps to regenerate their skin more quickly.
That
So
would
that's
make
my,
Yeah,
my experience.
that
So
would
I
make
think yeah,
I don't think I probably haven't noticed it.
yeah,
I haven't picked up on that, but
yeah,
I could
yeah.
see that. That makes a lot of sense.
Yeah, and in terms of fat, where the fat grafting would occur, you're saying in a male you don't put as much fat in to create
It's not
as
that
much.
it's subtle differences.
Yeah.
We don't want to often
Why they
widen by zygomatic distance, but we
okay?
do want to broaden the jawline. So there's a tendency to put a little bit more in the jawline versus the cheek,
I
uh,
get it. Okay.
and some other kind of key differences. The male chin is broader relative to a female chin, so I'm more likely to fill these areas. I'm less worried about widening the chin, whereas for women, I'm more worried about it.
Ah, I see. So that triangular ideal, it doesn't fit exactly with men,
No.
correct?
Yes, correct.
It's an inverted
Yeah,
or inverted.
yeah,
It's actually a correct triangle. It's wider on the bottom and narrower on the top, whereas
yeah,
women want it narrow on the bottom and wider on the top.
yes, yep,
Correct?
yep, totally.
Okay. And okay, so now in terms of facelifting techniques, uh, do you do a deep plane facelift? Do you do a smash facelift? These are different techniques. Do you need to do? How often do you do just a neck lift, a neck lift alone, without doing anything on the cheeks and the face? What is the frequency of, say, choosing doing a neck lift versus a full facelift?
Yeah. So the great part about this is I really leave it up to the patient because so first let me just describe the least invasive option I have. We call it a short scar neck lift. We just make a submental incision here and
Mm-hmm.
we focus on removing deep volume, right? So we take out the deep fat, we trim a piece of each salivary gland, we shave down the digastric a little bit, and we
Mm-hmm.
do close the platysma back up. The platysma is not super tight, but it's snug.
Okay.
And that alone, I usually, when we have visitors, I usually tell them 80% of the improvement in the neck is just related to deep volume reduction. The other
Okay.
20%, I think, is skin and muscle, tightening. And the cool, just for the same reason you just mentioned about laser resurfacing,
Yeah.
the male skin is better because of the beard. right? So when we do one of these techniques, because if you notice, I didn't talk about any skin removal, right? We don't remove any skin through this
Mm-hmm.
incision,
Mm-hmm.
but taking away that deep volume allows the skin to kind of re-drape into those spaces. And it's sometimes really shocking. I show patients like, hey, I didn't take out any skin on this before and after, and they just can't believe it because of that impact that the deep volume has. And for men, I'm willing to do that operation at any age. I've done it up to, I think the oldest guy I did was 75, got a great result, a teeny bit of
Yeah.
skin laxity, but he loved it. And so for the man who's really motivated to not have any scars around the ears, I offer that to every single male and have never been disappointed in the result.
And so it's purely isolated to below the neck. It's a submental
That's it.
incision right below the neck, and that's it, and nothing around the ear at all.
Right. I do that
Wow.
very frequently in men. So probably
Wow.
if I were to say face and neck lift versus like isolated neck lift like this,
Mm-hmm.
um, in men, it's probably 50-50, right?
Oh.
Whereas in women, it's probably more like 90-10, right? So
Oh.
in
Okay.
women, if they're under 45, the skin and the jawline is not a big issue. And so I can do a short scar neck lift for them. But my women tend to be like in their 30s. My men tend to be 30 to 60. You know, it's a broader range.
Oh. Okay. So they're
Well,
young.
number
They're
one, because they
relatively
do
young.
better with it. Number two, because
Okay.
of the jawline shape that I mentioned, we're not worried
Yeah.
about it as much. And number
Yeah.
three, men just tend to be a little bit more conservative.
Okay. And they want to preserve a more rectangular contour to the face rather than that oval shape that you described for women, right?
Yes. Yeah.
Uh-huh. Okay. And but how about how much does the fat grafting play into this? So
Yeah. For the men, so I kind of lead with the neck because most of them come in, as that their primary concern. If they're in their 40s, but 50s for sure, they're going to have a little bit of pan facial volume loss. And
uh-huh.
so if I get a sense that they're open to talking about more stuff, the next simplest thing I think we can add to this sort of treatment plan is fat grafting because again, there's no scars. And it
Yeah.
really, in this sort of middle part of the face, I really believe the diagnosis is volume loss. And so adding fat gives me a tool to basically treat the middle part of the face. Now I'll add it everywhere. Usually when I do fat grafting, what I've evolved to in fat grafting is a concept of putting a little bit of fat everywhere instead of really hammering away at certain areas. Sort of a little bit of fat distributed everywhere seems to be the right logic, So
Okay.
I'll often fill in this little indentation in the forehead, right above outside of the corrugators. There's a depression. I'll fill a little here, a little in the temple, a little over the cheek, the mid face, the under eyes, often the upper eyes. Blending down. We don't want this too sharp of a transition from cheek down. Jawline to kind of strengthen it, because sometimes that weakens. And if a patient just naturally has not good shape, we can use fat grafting to treat some congenital things too if they want to. So for instance, say it's a male with a really narrow jawline, I can build that up a little bit more to balance out their face. So
Okay.
that combination is a great operation. Short scar neck lift and fat grafting. I love that operation for men.
Oh. Okay. And you kind of said the patient directs the show in a sense.
Well,
I mean, it's interesting because sometimes I come into a patient, I start telling them, they ask me what do I think, and then I say X, Y, and Z, and I sometimes I think I'm overwhelming them with what I think is the right way to go, but I'm just curious how other people do it.
Well, I guess the strategy I take is I like to give them all the options. I tell them which options are viable. So, for instance, if it's a female patient with really heavy jowls, but they're really just focused on their neck, I won't give them the option of just a short scar neck lift, right? I'll say, this is something I do for some young women, but it's not on the table for you. If I think it's reasonable, then I try to just give them the option so they can choose. It just happens to be for men that we can do more piecemeal things. It could be more sort of a la carte, just because of the fact that conservative is good, and there's we don't burn a bridge by doing it piecemeal, and
Yeah.
it doesn't create a problem really. It's just it might not be as good as we can make it, but I'm kind of less dogmatic, these days about pushing, you should do this because that's going to look the best.
Yeah.
I've kind of
I'm not
backed off.
dogmatic, but sometimes I say, if someone comes in for a brow problem and I say, for their eyelids and their brow is way down, I have to say, you need a brow lift,
Right. Yeah, I will not hesitate to do
yeah,
that. And I will
yeah,
go to the extreme if it's really severe. If their brow's like this and they're
yeah,
asking for, lower lids, upper lids only,
yeah.
I will go to the extreme of saying I can't do it. I can't give you a good
Oh,
result if you don't let me touch the brow. It just
oh,
depends on how severe the problem is.
okay, I got it. And that does bring me to another question about, how do we deal with their. I've had frustration with brow lifting in some men because their skin is thicker on their forehead, and I've been very aggressive trying to do it endoscopically and trying to raise their brow, and sometimes I can't get that brow up to the level I want.
Yeah.
And my question is, it's a little tricky. The brow is a little tricky area, I think, in terms of men. Maybe you can for our listeners, maybe you can outline what is the difference between the brow contours and eyelid contours in men versus women.
Sure. Um, in sort of broad strokes, the brow is flatter, so it has less of an arch. That's kind of probably the key difference between male and female brows. But ideally, we want to see the tail of the brow kind of along the same level as the head of the brow. With aging, the outer brow comes down, right? This is how we age, not like this. So
Right.
in the 80s and 90s, when we were doing full endoscopy, I wasn't doing it, but when that was being done, everything was raised, and that was an incorrect aesthetic, which is
Mm-hmm.
good because now we can do less invasive things to make the change in the brow. I will say that educating patients on brow aesthetics and upper eyelid aesthetics, it's really challenging because there's many factors involved. There's understanding the way the brow changes. There's understanding the impact that has on the upper lid. There's potential volume loss. So you get loose skin, but then the skin retracts because of volume loss. And then you have your frontalis, which might be holding the brow up. And ultimately, you don't know what it's going to do after surgery once you treat your brow and upper lid. So it's this, like, there's multiple factors influencing where that crease sits, in your
Yeah.
in your lid. So so going back to the brow, the key
Mm-hmm.
really is the tail of the brow, getting the tail of the brow up. And for men, what I like, often they'll have kind of bushier eyebrows like me. So I really like the direct brow, just making an incision right over the outer part of the brow. The downside of the direct brow is, it's this skin that's lax. And obviously the brow stops and you can't keep coming out like this. So it doesn't allow you to take care of this stuff, especially if you're doing a facelift and you get bunching here. You're not going to take care of that with a direct brow.
Right.
Um, a forehead crease will work better. If you make an incision in a forehead crease, often it'll come out a little further. That's actually a good way to do it too. Once in a while, patients will have a really good hairline, and I'll put a scar up here. But basically, it's the closer you are, the better the effect. So this is actually the easiest and the most effective.
I don't like a direct brow lift. I've done
Why?
them.
What do you not like?
I don't find I get a nice. I still can see a scar there, no matter how careful I am in closure.
I
And
will. Yeah.
go ahead, I'm listening. I
No,
want
no.
to hear your thoughts
I,
about this.
I think the inner half of the brow, that skin is very different than this temple skin. I
Hmm.
find that, yes, I agree. Once in a while, the scar is not great, but it's usually only in the medial aspect. The lateral
Okay.
part seems to do pretty well. Um,
Okay.
I mean, I take my time. I close it with, 6-0
Layered.
interrupted nylon. I mean, we try really
Mm-hmm.
hard, and
Mm-hmm.
yeah, once in a while, it's not great.
How about a
But
sliding? How about a gliding or sliding brow lift? What
Yeah,
do you think of that in the male?
I haven't done it on a male yet. I've done maybe a
Okay.
handful.
Okay.
There's one I actually just did our office manager, and she's posted on Instagram. So if somebody wants to know what a gliding brow lift is, they can check out my
Okay.
Instagram. But it's weird when I show patients. They
Yeah, I
either
know. They
they're
get
like,
scared.
but so sometimes, but I think it's reasonable. It would be a way to. Francisco Bravo in Spain does this thing where he does the direct brow and he does the gliding. So that way he's getting this laxity up as well. So it's something you can combine with other techniques potentially. I've been mostly happy with it, but it's a little more unpredictable.
Really?
Taking out tissue is the most predictable way to raise the brow. Taking out tissue closest to the brow is the most predictable way to raise it. As you're doing sort of subperiosteal lifting and gliding brow stuff, you're not removing tissue, and that creates a little bit more of a um, uh,
Uncertainty?
yeah. And then the one other thing that I've really shifted towards doing more subperiosteal, subgaleal to all subcutaneous now, because especially in patients over sort of 50, 55, you could raise the periosteum, but this skin is so lax that there's two planes of tissue there, and the skin's, even though the periosteum comes up, the skin's still going to kind of slouch back down. So I think it's the skin layer that we need to treat in this thin tissue, and so I've gone more towards subcutaneous hairline in a woman, so obviously subcutaneous direct brow in a male, and
Well,
gliding brow in young
mean,
people.
a subcutaneous dissection is really a gliding brow lift, except for the hematic, sutures,
Right,
the
right,
net. I mean,
right.
it is a subcutaneous
That's right.
brow lift, really.
That's right.
I
Right.
think.
You're
I
doing the
think of it
same
as,
dissection. You're just
yeah,
either you're tacking all the skin up or you're excising it. That's
yeah.
the only
But do
difference.
you think it's risky in a man because you can overcorrect the brow?
Yeah, I mean, you often have to overcorrect a little because you lose a little bit of the effect. That's one of the downsides of gliding brow lift, the predictability of it. Um, yeah, I haven't done it, and it's funny. This is the first time I've thought about it actually,
Okay.
because I've kept it simple for men. Just doing sort of direct brows. But um, yeah, I mean, I think I would try it. I think I guess it depends on the male, and but you're right. I would be more hesitant because I would hate to put them through sort of 2-3 weeks where they think their brow's too high. I think that's less tolerable for them.
Yeah, they may get scared. It's a little scary to look at too.
It
The
is.
sutures, for a patient, I show pictures of that, you know, pre-op pictures of the patient or intraoperative pictures, and they get scared from the
Yeah,
sutures. Even the first
I
time I
get.
saw it, I freaked out. I said, "There's no way my patients are going to tolerate that,"
I know. Yeah, I
So,
cover it with tape so they don't have to see it, and the sutures come out at
oh,
for the people out there. The sutures come out in 2 or 3 days, so it's not a
yeah,
really long period of time to
yeah.
freak out, but it's freaky.
Okay. I'm going to backpedal a little bit. I thank you for that info. Oh, wait, no. Before we go forward, you didn't discuss. I think there's a very important uh, place to discuss where the eyelid crease in a man should be, an upper eyelid crease.
Yeah.
I'm obsessed with this, and I think there's been a lot of mistakes made, a
Okay.
lot. And I see a lot of post-op pictures, and I say, no, they screwed it up. So let me hear what your thoughts are, where you think the eyelid. I'm putting you on the spot, by the way.
Yeah, I feel like I'm being tested because you're the eyelid expert. So I
Right,
better get the answer right. Uh,
right.
Before we say that, let me just say that in men, we definitely don't want a lot of exposed eyelid. So again, goes
Mm-hmm.
back to my point of conservative. But it seems like the lid is heavier in men, and on average, I'd say the crease is a little bit lower. So maybe, I mean, where I mark it is I try to mark it in the natural crease. That's what I'm aiming for. I think that tends to be around maybe 7 or 8 millimeters, for men, something like that. What do you think?
Dino, no,
No?
don't go there, Dino.
Where do you go?
Only because no, this is one of my pet peeves. My pet peeves is that even in women, by the way, I think the crease is way too high. Okay, in most cases, if you
Mm-hmm.
look like at a naturally unoperated on eyelid, I think men should be slightly below the natural crease. Okay, why? Because that crease tends to migrate upward.
Mm-hmm.
Okay, and so if you make it, if the crease is at 6 or 7, it should be at 5 or 6, and then it will look more natural ultimately in terms of and but at least I mean I will tell you that crease position is a very funny subject because I presented some of this subject at a meeting in Cleveland, and I asked the crowd, I said, which crease do you like? Okay, and I showed one that looked what I call unoperated on, which is a low crease, and then the second patient I showed with a high crease, and 50-50, half the crowd liked the high crease, which looks to me operated on.
Mm-hmm.
If we're really aiming for a natural look,
Right.
I think you got to go low,
Yeah.
especially in men. Especially in men, you can if you touch their brow and you raise their brow, and that crease will go a little higher. I think you got to keep your crease low,
Yeah, I
and I
definitely make
think
it lower in men.
yeah.
But I generally put it in the natural crease. So maybe I'll
Okay, okay. Well, look, just you could put that in your hat and think
I
about it. But
will.
I'm just,
I will.
but I think you'll see if you really analyze it. I don't want them to look done, and I don't want
Yeah,
them to look effeminizing. If you put a high crease in a man, you can effeminize their upper lids very easily.
yeah,
And I learned that early on from Henry Bayless. I don't know if remember Henry, but he was
mhm.
at Jules Stein, and he was an outstanding guy. Now, I'm going to ask you about uh, the what I'm fascinated. I want to hear about your facelifting technique,
Mhm.
specifically in men, because and that's really the subject we started with. So, how do you do, what do you do? Do you do a deep plane facelift? Are you doing a smash lift? Are you doing an extended smash lift? What's your approach to men?
So I don't vary that technique, men or women. So the technique I use, for me, it's basically this is what I'm doing to raise the jowl area, right? So I think of the tech. I don't change that. The things that vary on a male, other than kind of the planning that we've already talked about,
Hmm.
incision design is really important. Um, Having imperceptible scars might be even more important than women for many reasons. One, because of just society's view on male aesthetic surgery versus female. But the hair is
Not
going to be short.
acceptable. Hmm.
Yeah, a
Yeah.
little bit less acceptable, maybe, but that's
Hmm.
probably changing. Um, Shorter hair, so harder to conceal scars. And then we have the beard to deal with, which is create some new tricky things here. So the key modifications are, in a woman, I make an incision around the hair, a rounded incision below the sideburn. For
Hmm.
men, we make it very angular. We create like a very sort of angular sideburn. Now, some
Oh,
people
okay.
say, well, why don't you just go up in the hair like this? The beard's going to come up. The problem is when you do that, you can bring this hairline back and have
Hmm.
too much kind of exposed temple skin. But
Hmm.
also, what you're doing is you're pulling up beard into sideburn when you do that. And it's a little unnatural to have that sort of beard hair there are different types of hair basically. So I think it's actually even more important to preserve the sideburn in men compared to women. And that's often contrary to what people think. The other, I tend to go retrotragal, um,
Hmm.
men
And
and women.
and
Yeah.
that's been a controversy because in
Yeah.
in much of the literature in men they say, oh, just follow the crease right down here, and I
Right.
say that's terrible. It looks
Yes.
terrible.
Yeah, it
I
generally
think it.
does. Yes, because there's a clear textural color mismatch between the tragus and the cheek.
Hmm.
So when you bring that sort of cheek skin sharply right up against that tragus skin, that scar, even if it's a really nice line, it's the color that makes it look kind of visible. So that's the problem with that incision. But then there's an alternate problem to a retrotragal, which is if somebody like in me, where my beard is pretty close to my tragus, when that skin shifts back, you're going to get some hair on your tragus. In a perfect world, somebody has a very wide distance there, and then they're a perfect candidate for retrotragal. But it's basically choosing between a lesser of two evils. You know, would you rather have that more noticeable scar, or would you have some hair on the tragus that you need to remove in some form if you need to? I like that second trait, you know, the taking the second trait off. You know, I like the retrotragal approach.
Do you ever use, when the hair is displaced from the cheek over to the tragus, do you use laser hair removal over there, or do you pluck out the hairs because they grow asynchronously?
Yeah, you could flip the flap over in surgery and cauterize, you know, each follicle. That'll get probably half of them to die. And then, but then the issue is it depends on the color of the hair. You know, if they have dark skin and, you know, light hair, you're not going to be able to do laser surfacing. So the classic thing was, what's it called?
Electrolysis.
Yeah. And there's not that many people that do it anymore, but I think I found one somewhere locally here, but so
I know how to do it. Yeah, I have I have very fine needles, little electrolysis needles, and a.
I've never seen it done, so I'm not even sure.
Oh, it's no big deal. It's just you just have to put it on a monopolar cautery with a chuck. There's a little chuck and it screws in. It's a fine wire, and you just pluck it. Yeah. I hate doing it, but I mean, I used to do it on the eyelid when you get ingrown eyelashes. So you can imagine what a pain in the neck that is.
Yeah, that sounds painful.
I'm sorry, I cut you off though. Go ahead, tell me more.
So we talked about the tragus. For the lobule, same issue. If the beard ends up right stuck where the lobule is, that doesn't look like a natural transition. And so we leave a little bit more cuff of skin on the lobule. So maybe 2-3 millimeters versus just, you know, 1 or 2 in women. And that creates a better transition from beard to earlobe. And then behind the ear, nothing is really different. We stay in the crease. We kind of turn where the ear meets the hairline, so it's concealed. And then most of our incision is along the hairline. So incision planning, I think, is the biggest distinction in a true, you know, facelift only, you know, if we're not talking about the neck lift. And actually the neck lift is very similar too. As I said, the aesthetic is very similar. If you look at the best male and female necklines, they're very similar. So technically speaking, in terms of my SMAS surgery, I'm doing the same thing. It's this design and the aesthetics in terms of fat grafting and which procedures we're choosing. Those are the bigger differences.
Okay.
And just to answer you what technique I use for the SMAS, I've had an interesting journey. I started doing a high SMAS flap, and at some point early in practice, I was trying to do the neck and fat grafting, and, you know, the cases were really long. So I thought, you know, the famous Dan Baker did, you know, probably has done more facelifts than anyone on the planet, you know, at this point. And he had done flaps in his early days, you know, but he went from smasectomies to even less invasive, in a sense, plication, and was happy with it. And he wasn't doing fat grafting and all these kind of confounding variables. So when I kind of thought about that, and, you know, he's a smart guy and he's been doing it a long time, I thought, well, let me try plication instead. And let me just do everything else I'm doing. I'll do all the deep neck work, all the fat grafting, but I'm going to plicate. And I was really happy, actually. I don't think my results changed from high SMAS to plication. I've evolved.
That's fascinating. That's fascinating.
I've evolved to something else now, which I'm going to publish at some point. So
okay.
I mean, I don't, you know, it's not that big of a deal, but it's a little bit more of a hybrid thing where I'm doing a mix of a plication and a SMAS flap. So it's sort of like, see, for me, you know, and you might not like this if you do deep plane, but I believe that a deep plane facelift is all added risk with no reward, in my opinion, because once, you know, in the plastic surgery world, and you know, we're all taught different. Our lineages of teachers are a little different, so the emphasis tends to be different. But for a long time, there's two kind of key consensuses in the world of plastic surgery. One was, once you get off the really strong ligaments, like the zygomatic ligaments and the parotid ligaments, once you get off that area, the ligaments are really loose. Like, you see the clinical effect. You pull on the flap and everything moves, whereas before that, it doesn't. Once we get the clinical effect, we would prefer to stop dissecting, because as you're coming off the parotid anteriorly, it's dangerous. It's hard to tell what's a ligament, what's a nerve. And a nerve injury,
I'm glad you said that. I'm glad you said that. And I've seen, quote, the best people, quote unquote. I'm not throwing stones. I'm just telling you that they're dogmatic about doing deep plane, and I've seen plenty of complications. Plenty. I'm not saying that it's not a good technique. I'm just saying it's. I
think it's a good technique, but I think it adds that risk to a nerve injury. And the nerve injury, we want complications that are easy to manage, that we can fix. Complications that are kind of unfixable, I want to avoid at all costs. So for me, the trade-off of deep plane versus even something as simple as application, it's not worth it to me, What I've done is now I release off the parotid, but I plicate anteriorly. I just gave away my secret.
Secret sauce.
I plicate anteriorly, and then I raise a flap laterally, and I really liked it, because the flap now, because it's been released off the parotid, its point of effect is more towards the jowl versus distributed along the jawline. And that's all I'm trying to do with my smash surgery, is get the jowl up. That's all I'm aiming for. And I think it does it a little bit better than my plication, but it's not really that different. For the young surgeons, I'd say plicate for a long time before you try something else to be really safe.
Yeah. I think that's where I made some of my errors early on. I was trying to imitate some of the people of my day, which were like Hamra and stuff like that, and trying to do that. And I got into trouble. I got into trouble early on because I was going a little too far forward, as they say. And fortunately,
it's a big distinction.
And
because like Tim in the office, when I ask him, rate a nerve injury. Other than a couple maybe like partial, or temporary temporal branch things, which are more related to the brow lift. If we're only talking facelift, I bet he'd say it's 0, actually. And I can say that mine, up until this year, was 0. I had, what's really interesting is I had a couple temporal branch, temporary things from subcutaneous, because I was doing it on this really patients that were much older, and they had very, very thin muscle. And I must have just gone through the muscle and, kind of dinged a nerve branch. But basically, what that means is if you elevate a very careful skin flap and you plicate, I think the rate of nerve injury is basically 0. And that's a good trade-off, given that I don't think the effect is any different.
Yeah, but I have to say, in your defense and in Tim's defense, that you guys have perfected the neck. And because you've perfected the neck so well, that you're kind of like you're 75% there. If you know what I'm saying?
That's good. Yeah.
And
and
you know what I'm saying? Once you start, once you're tightening this, then you don't need much here, as they say.
Well, that's the classic thing they say. Your face and neck lift is only sort of as good as the neck lift result. That's
okay. I didn't hear that before, but okay.
Something like that.
Well,
I paraphrased it.
Listen, this has been a great. Yeah, go ahead.
Mention one other thing. The other key concept in the plastic surgery literature is this idea of the twin study. Have you ever heard of it?
Yes.
Yeah. So really interesting,
well,
right?
Well, the twin study that was Aston's paper, I think.
It was
Cheryl Aston or someone like that.
Write the paper. I can't remember who's.
I don't know.
The surgeons were
they took one half the face and they
Well, no, they had 2 twins. And one
twins.
Did one twin, the other did the other.
Oh, yes.
Aston has a case where he did plication and smash flap.
That's what I was thinking of. Yeah, okay.
I actually did that. We did that at a live surgery where we did a deep plane on one side
Yeah.
and plication on the other, the patient looks the two sides look the same. So, you
That's
know,
fascinating. That's really good stuff. You
yeah,
know, I tell you, what's so interesting about facelifting is no matter how vociferous the person is in front of you, claiming they're getting the better results because of what they're doing. In the end, it may not matter.
right, yeah.
Even I thought I was getting better
Yeah,
results with a deep plane, more aggressive. I thought I get greater longevity. That's the question. Do you get the same longevity? What do you think?
yeah, I think so. I mean,
You
once the
do?
tissue heals, it doesn't, I don't, that was the old thing, right? That like, oh, it's going to kind of recur faster if you don't do a flap. That's not been my experience.